Hello there, my name's Dr. John Best, Sports and Exercise Physician at Ortho Sports. Thank you very much, Daron, for that introduction, and thank you to you, Catherine, and the team for putting on another orthopaedic and sports medicine update with Ortho Sports. It's great to have everyone coming in live. We know there's a good number online. I'm sorry I can't be there with Paul Mason and Paul Annette. We're in Adelaide at the moment with the Australasian College of Sports and Exercise Physicians annual conference. Lee Golding has been away with the Australian cricket team, and at the time of recording, I'm not sure if he's smiling or not. We'll see about that. I'm just sharing some thoughts on the assessment of rotator cuff deficiency. I've been thinking about this for some time because of the discrepancy we often have between how patients examine and what their scans look like. An interesting paper was published earlier this year in BMJ Open, a British paper. The lead author was Hensley. It's a 20-year cross-sectional study of over 1,000 females. And what they found in these women who are over 60 years of age is that the prevalence of unilateral tendon pathology or a tear was almost 60%, and of bilateral findings was over 30%. And as they went through the age groups, the 60 to 69 year group was 50% and 24% bilaterally, the 70 to 79, 61 and 32%, and the 80 to 89 year olds were 72 and 40%. Now their criteria on commenting on rotator cuff disease was the Oxford shoulder score and also ultrasound findings. But what they found as they examined patients is 50% of ultrasound findings of tears were actually asymptomatic. So the cause of these patients' pain was a little bit unclear from time to time. And this is the dilemma and this is the discrepancy. Now, one of the other issues is our growing older population, of which I'm approaching that phase, having turned 60 a couple of weeks ago. The Australian Bureau of Statistics last year reported that our over 65s population outnumbered the under 15-year-olds in Australia, and by 2051, about a quarter of our population will be over 65 years. Now, with that, there's been a real movement and teaching and a lot of literature, social media about healthy aging, and I lecture on that topic and I enjoy it and I try and practice it. And with that is the finding that active retirees often do new things, new activities, which is fantastic. In the Western world, about 20% of people will have shoulder pain at some time, so a significant number, and shoulder pain comprises 30 to 40% of all musculoskeletal pain. So we're talking about a common issue. So I'm going to present two cases. The first is Alice, who's age 50. So meet Alice. Alice has been enjoying swimming and yoga, and prior to her presentation had increased in her physical activity of both. She developed some vague shoulder pain swimming, which bothered her at night, and she was better with non-steroidal anti-inflammatory tablets. She came without an x-ray. She'd had an ultrasound through her general practitioner. There was only a report and I couldn't access the imaging visually. And on your handout in the introduction, I've commented on that report, which says, there is a degenerative tear of the supraspinatus tendon at its insertion. With a partial tear of infraspinatus, the appearance suggests tendinopathy. There is fluid within the subacromial bursa and features of impingement. So she had stopped all her favourite sports, swimming and yoga. She was very scared about damaging and making this tear a big one. And she came hoping we would do platelet-rich plasma injections because she'd read up on tendinopathy. She actually did well without much treatment at all, to be honest with you. She needed some rehab and scapular positioning work to reduce her impingement. But I'll come back to that and I'll show you her ultrasound. Meet Jeff, who's age 62. Jeff's a male who restarted gym training some 2 years ago. He's always been active as a gardener, but he also, in his gym training, was keen to push his bench press, and he was doing some training with his son, who was a lot younger. He developed some vague ache in his shoulder that was injured, and this had occurred for about a month or two prior to him injuring himself when he was digging out a tree root in his garden, and he felt something go in his shoulder with an immediate feeling of pain and weakness. He came to me 3 months post-injury with an x-ray showing AC joint changes, which were moderate at worst, a subacromial spur, and sclerosis around the greater tuberosity. I'll show you his MRI, which shows a full thickness tear of the supraspinatus without any retraction, no atrophy, mild subacromial bursitis, and some posterior glenoid changes. Alice did very well. Here's her ultrasound, which shows a footprint abnormality here, some fluid in the bursa, which is not extreme, and quite frankly, it's reasonably benign. It's not a particularly bad ultrasound. So I think it got over-reported when we finally had a good look at it, and she did very well with a rehab program. This is Jeff's MRI. As you know, an MRI is a big magnet that measures predominantly hydrogen atoms, and the whiteness is fluid. He's got a lot of bursitis, that's for sure. He's got AC joint changes, some spurring, and there's the tear of the supraspinatus insertion with some tendon abnormality. Now, Jeff is about 6 months following this scan, and he's pretty well asymptomatic, and it's largely because he's changed his activities. He's stopped doing overhead and forward pressing movements. He's quite happy with his levels of activity, and we're just monitoring his rotator cuff to make sure he doesn't weaken and the tear isn't retracting. So this issue of what do the scans show and how people behave, it really is quite variable. I've referenced an article by Creech and Silva, who published in the United States early this year at the National Library of Medicine. You can access that, which gives a good overview of shoulder impingement syndrome, historical features, examination features, and so on. And what I want to do is go through some poor prognostic features for you. So if in the acute injury setting, a patient immediately has weakness and immediately has night pain that really doesn't go away, they'll tend to have ongoing problems, and you need to be suspicious of a tear that's not healing. Again, our differential will include neurological injury and so on, so don't forget that. In the more chronic setting, it's the patient who's no better with rehab, or the patient who's had a subacromial bursal cortisone injection which hasn't helped at all. Again, you'd be thinking of a tear that's not healing. The red flags of severe night pain, sweating, or radicular features, don't forget those. And I'll be hammering you about getting an x-ray, which I'm sure you all do. And don't forget to check compliance for exercise. The patient who says to you, I can't remember how I do those exercises, who isn't compliant, they tend not to go very well. From an examination perspective, there's a few poorer prognostic features as well. Reduced active motion, but not due to pain. So someone who actually can't move their arm in certain directions and they're not inhibited by pain is a bad sign. Again, that can be neurological. If they have weakness in more than one plane, that's a poorer prognostic sign. For example, if they display a forward elevation weakness and external rotation power loss, they would have a more extensive injury to supra and infraspinatus. If despite 3 months of appropriate physical therapy their weakness persists, then that needs further assessment. And once again, our non-compliant patient, if they can't demonstrate their exercises, that's a poorer feature. I found that there is some confusion on assessing the rotator cuff, particularly if you're testing strength in impingement positions, which is the way many impingement tests are performed. So the Jobe or empty can test, the NER, NER impingement sign, the Hawkins test, all of those can create impingement. The drop arm test can as well, but the purpose of the drop arm test is to see if a patient can control their arm as they lower it. With tears of the rotator cuff, they lose that control and the arm just drops down. So with that in mind, we do remember the lift-off test to test subscapularis, and here's an elegant MRI showing a post-dislocation injury of the subscap. This should be there. This is in a patient with a lax glenohumeral joint, a big voluminous capsule, type 2 medial insertion of the capsule on the glenoid. What I'd like to do is introduce you to what I'm calling the lift-up test. And the idea here is we're wanting to load the supraspinatus in a position of non-impingement and in a position of slight hyperextension. So this patient here came to me after a traumatic injury, has had shoulder pain and feels it's weak, and he had positive impingement signs. It was hard to test his strength properly. So this is him just moving against gravity, and I'll show this through a couple of times. And this is him lifting. And you'll notice that as he lifts up and down, his shoulder just is a bit wobbly. His control isn't great as he brings it down. Now, on the right-hand side, this is me resisting him with 2 fingers against gravity.
Push up again.
And he's just having a lot of trouble with that.
Okay,
and if I turn the volume up high, you'll hear this poor gentleman groaning because of the pain, but he just can't do it. So he can't lift up his arm off the bed. So I'm calling that a positive lift-up test. Lift up.
Lifting it up and down. Physio, push up again. Push up again.
Okay. And he can't do that. Now these are his x-rays, and on his AP film he's got a lot of spurring going on. Subacromial spurring, AC joint changes, sclerosis around the tuberosity. And on his axillary lateral, which is not a good quality film, I'll grant you that, there's subacromial spurring there as well. And on his MRI scan, we can see here that there's a significant tear of the supraspinatus, which is meant to be attached down here. Tendinopathy changes, spurring. And on the sagittal film, unfortunately, has also a lot of muscle atrophy, which is a bad prognostic feature. You can't pick this up well at all on ultrasound. Also, you can often get fat delamination and fatty infiltration into the muscle belly, which is a poorer prognostic feature, whether you're treating them surgically or non-surgically. So that's the lift-up test. The second test I want you to think about, I'm calling the shoulder retraction test with pain change. So when your patient displays impingement signs, frequently, and we've all seen this over time, they develop a poor posture where they're falling forward, their trapezius is hyperactive, there's weakness of their scapular retractors, of course, and they may often have a hyperactive pec major muscle. What you want to do is, when you've done your impingement test, ask them to pull their shoulders back, squeeze their shoulder blades together, bring their neck back, and redo their impingement signs. Patients often have less pain, and you can test their strength a little bit better as well in that position. And what I explained to them is we're creating space anteriorly, we're creating space for the anterior part of the rotator cuff and the bursa, and probably the long head of biceps as well as they elevate their arm and so on. So shoulder retraction and pain change. And the final thing, and briefly on this, and I know you're all aware, but it's a good reminder, people are doing different things these days, so we need to be a bit better with our functional testing. So those patients who are doing body weight-bearing activities such as mountain climbers, such as your chaturangas, which I've got to say are very good for my practice, we need to test them well in abduction, external rotation, and ultimately with weight-bearing, initially with a close grip and then a wide grip weight-bearing. So let's talk a little about image as I start to wind down this presentation. Do get an x-ray, please, and ask for a lateral film. And often you'll see a big spur. So this is a supraspinatus outlet picture. There are variations of acromial shape, as we know, types 1, 2 and 3, or an unfused epiphysis. And patients just love seeing this big hook here. They say, "Doc, how do we get rid of that? Doc, has that always been there? Doc, an injection won't get rid of that, will it?" And I say, "No, it won't. But," I say, "we can change the angle. We can change the angle and maybe it'll stop cutting into your tendon and the bursa." There's no question that an MRI with arthrography is a far superior test for the rotator cuff than ultrasound. There are 2 papers I've put there for you. The Sanders article from 2015. It's a really nice article looking at reading MRIs of the shoulder. You may want to check that out. And the Okarora article published in Ultrasonography in 2019. It's an American article which is helpful. One of the tricky things with some ultrasound studies is that they can be industry sponsored, the manufacturers of the ultrasound, so just keep an eye on that. This is the same patient. This is the same patient where there is a defect in the footprint and a little sort of split here, but they've actually got a full thickness tear of the rotator cuff. They just didn't get the angle right with that. And one of the advantages of the MRIs, you can now, obviously electronically, we see them all the time, and we see them like a movie where virtually we can see them 3-dimensionally. So, Daron, as I wind up, I want to thank everyone for their attention. And when you consider, again, your assessment of the rotator cuff and deficiency, please remember that there is a discrepancy between the patient's signs, their power, and what these scans may show. And think about the lift-up test and also the scapular retraction positioning when you test their rotator cuff and assess their impingement. And get an X-ray if they have shoulder pain. Thank you.